So I will eat up the coffee break now, right? Okay, try to be fast. So I was asked to give a talk about immune therapy and targeted therapy, what's new. And I will bring some examples about what's new, but not the whole global perspective to say this. And yeah, I think add to there. No. Okay. This is just from a paper, and these are types of immune therapy that you could apply, and we will not discuss all of them. I just have chosen immune checkpoint, CAR T cells, vaccines and antibodies, and I will give some examples on trials or ideas that are already on the road. We have a dilemma in bone sarcoma with immune therapy. If you read newspapers or watch news, immune therapy is the new magic bull against all cancer. This is just not true. In bone sarcoma, we have the problem that they are, we call it quiet cancers or immune desert, because they often do not have too many additional mutations, which is specifically typical for Ewing sarcoma, because they have this translocation and are otherwise quite quiet, but also osteosarcoma, which is for a sarcoma of young people, an already chaotic tumor, has not as much mutations as the average adult type cancers, lung cancer, colon cancer, and so on. So we have to think here really different. There were trials using the immune checkpoint blockade. That means the idea is that around the tumor there is tissue that would prevent the immune cells to enter the tumor and to kill the tumor cells. I mean, you will know, like every day in our bodies there are cancer cells developing, and usually our immune system is capable to kill them. Because of this specific environment, when a tumor grows, they are not longer capable. And there's this CTLA4 and the PD1, PDL1 pathway, and there are two drugs. I always thought my children playing with Pokemons can remember these drug names better than me. So this is nivolumab and ipilimumab. And there was a clinical trial also including bone sarcoma patients. And this is Ewing's and this is osteo. And as you can see, they stop here kind of early, so it obviously didn't work. It did work partially in one Ewing sarcoma patient. The issue is that with such a trial, usually you would say, okay, that drug is kind of dead for this disease. On the other hand, it was not too many patients included in that trial. This is sometimes a difficult thing that we have to consider. And I also found a case report on a 37-year-old male patient. Diagnosis, Uramos treatment, surgery, first relapse, just surgery, second relapse, just surgery and radiotherapy. Next relapse, not capable for intense chemo. This was a metastatic relapse where you would consider to give chemotherapy, but he had like a kidney damaged, and they saw that there was kind of a high expression of PDL1 in the tumor cells and also in the surrounding tissue. And so analog to that study, they started with this ipilimumab and nivolumab, and there was a dramatic response in this patient. And then the patients got severe side effects, pneumonitis and palsy, so they had to stop the combined treatment, and he's now like on nivolumab and kind of cured for more than a year and in a good condition and back to work. And here you can see the response. So there were really here metastases all gone in the brain and also in the knee here. So it's sometimes worth trying. Yeah. Okay, next story, CAR T cells. CAR T cells are specific T cells where you introduce a vector that targets the T cells against a target. And so you need a target. And on sarcoma cells, we would like have HER1, ROR2 or ROR1 and, for example, GD2. And you take blood from the patients, put the translocation in, retransfuse, and hope that the CAR T cells will kill the tumor. And there was an enormous push forward in patients with leukemia. So this is the curve of very high-risk leukemia before CAR T cells. This is the curve after people starting to give CAR T cells, and this is the poster girl. This was one of the first patients who received that CAR T cell, and she makes a picture like every year and is now a healthy young lady. In leukemia, it's a bit easier because these T cells go through the blood vessels, and wherever they go, they find an enemy and they can kill it. And that makes them also kind of stronger. And in bone sarcoma, we have again this dilemma of the immune desert. We have our surrounding tissues that would prevent the lymphocyte to enter the tumor. So you have to be a bit smarter and not only to target the tumor cell, but also find a way to trick the environment. And there is a trial upcoming. There's one trial already ongoing in Roma, also including Ewing sarcoma cells with a anti-GD2 CAR T cell, which is kind of a good target for Ewing sarcoma, osteosarcoma, also breast cancer. And we will start in Germany also a clinical trial led by Claudia Rössig, and they developed a CAR T cell against this GD2 with some additional markers that would trick out the microenvironment. In this case, it's IL-18, but you could also use different ones. Yeah, and we will see how that goes. Then I would like to bring some concepts that the European 2 Ewing sarcoma study group and the osteosarcoma study group is working on, to bring also new concepts first line. And in Ewing sarcoma, the need is for the high-risk Ewing sarcoma, but because metastatic Ewing sarcoma first line is apparently not curable, the survival rate is 30%, even if you give high-dose chemotherapy or whatever. And there's one trial, IUR Ewing, and the concept for the high-risk patients is to give a standard protocol and to allow phase 1 and 2 protocols, and I will show you the phase 1 and 2 protocols that we are planned to add in a minute. One is a vaccine protocol. It's called Pervision, and it's already started. And the idea is to produce a custom-made vaccine for the patient. So what you need is, in a patient where you know it's high risk because it's metastatic disease, You take the tumor, you sequence the whole tumor, you produce your vaccine, and then after you have seen that the patient is in remission from the normal chemo, radiotherapy and so on, you can apply the vaccine. We know these vaccines already also from leukemia treatment. Side effects are usually that you might get a granuloma and like an inflammatory reaction at the site where you inject the vaccine. And here's again the concept. So at surgery, you do sequencing. Then it really takes 4 to 6 months to produce that vaccine. Then you have to see whether the patient is in CR, and then the trial starts to add the vaccine. And this is something that we would like to add in the IU reviewing protocol, like 3 months restaging and then go into that per vision protocol. And we hope that we see effects in at least some of our patients. The next, we already learned anti-GD2, that you can produce CAR T cells against this, but as pediatricians, we know anti-GD2 since ages, because you can also give an antibody treatment against anti-GD2, for example, dinutuximab. Which we give in neuroblastoma patients, and there were case reports that this was very effective parallel to chemotherapy in those Ewing sarcoma patients that where the tumor expresses GD2, which is not the case in all Ewing sarcoma. It's like in about 40%. And so together with the company, we designed a phase 1 protocol to give this anti-GD2 antibody together with chemotherapy. You have to do a dose finding. And the idea is also in the high-risk patients, for those that express this GD2 on their tumor, to introduce this first line in the high-risk protocol. This will be also only like for 30% of the patients. The next story is volasertib. We saw in Ewing sarcoma that about 20% of them express a protein. This is called PRC1. The pathologist can just see it by immune staging. If they express PRC1, the outcome is worse than if you have no PRC1 expression. And these B something is just volasertib, a drug that we also already know for treatment of more or less hematological diseases. They would kill the cells that have a high expression of PRC1. And we started a phase 1 dose-finding trial with volasertib and vinorelbine in Ewing sarcoma that are PRC1 high. And if that study is positive, we will add this drug for the PRC1 high Ewings also first line here in our maintenance phase with vinorelbine together. Another current hype in sarcomas are the so-called TKIs. These are small drugs that target different pathways in the tumor cells, and they usually target a lot. For example, you can see regorafenib targets a lot, carbo a few less, and there's pazopanib. And there were clinical trials for regorafenib and cabozantinib, and there's an ongoing trial for pazopanib. But these two trials showed positive results for Ewing and osteosarcoma patients. There is now the FOSTER consortium, a European consortium to fight osteosarcoma, and that consortium plans a clinical trial that would test the value of cabozantinib first line in osteosarcoma patients. It will be a randomized clinical trial, randomized against placebo. Yeah, I think that's a bit difficult because cabozantinib makes turns your hair white. So if you are in a big center and if the patients meet in the outpatient setting, you can see who gets cabo and who not. So yeah, but they will hopefully deal with that. But it's as anyway, we had for I think more than 10 years we had no osteosarcoma clinical trial except for France. They had one, so I think it's very good that also the osteo community came together, and it's very good to test a new drug in that consortium, and that consortium also has the power to bring new drugs in a row. Then we have the other European Ewing sarcoma group. The inter-Ewing 1 trial will also hopefully test a TKI regorafenib. Currently in France, they started the phase 1 clinical trial to see whether you can give the TKI parallel to chemotherapy. TKIs are kind of quite toxic. And if this is positive, this will be included frontline for the Ewing sarcoma patients and for all high-risk Ewing sarcoma patients. So not biomarker driven, but everybody gets that. And then we have now meanwhile a worldwide clinical trial, the RECOR trial for relapsed Ewing sarcoma, also started in Europe, that tests different arms. We started with just chemotherapy, and the new arm includes lenvatinib, which is also a TKI, which will be tested here. So I would say the bone sarcoma community is really quite active and really tries hard in these ultra rare diseases to bring new drugs to our patients and to our high-risk patients, and this was really not the whole picture, but just some examples that we are really thinking in all directions, and we will hear even more directions by Sue Burchill's talk after the coffee break, I think. Yeah. So. Yeah, otherwise all cake will be eaten by all the other groups. Yeah. I have. Yes. I know. Yeah. Usually, especially in this AYA and children's bone sarcoma group, we work very closely together. The European trial, it's really, again, very European. France has another standard backbone than MAP. And so in France, the cabo will be added to the French backbone, and I believe in almost all other countries we all use MAP. Foster is not only a European group, and we work very close together with Pat Groa and Cathy Janeway and so on. And I think the idea also for the Ewing trial was to include in our informed consent that the patients would agree to share data also with other trial groups, so which would make the trials shorter. And yeah. I think it's the same with Rigo. I think also the Ewing trial in the US will be with Rigo. So we will learn a lot about TKIs. And yeah. Yeah. Yeah.
The arm of the definitive radiotherapy, I saw the higher dose, more than 60 gray. Did you consider proton therapy?
So uh, um, we have in both trials, in the IO Ewing as well as the inter-Ewing, a randomized question on the dose of radiotherapy, and it's not, you cannot make it mandatory to use proton beam, but it's allowed. Yeah. Because we have some countries included where they don't have a facility, and sometimes it's really difficult to refer patients. I mean, in Essen we are quite international with our patients, but yeah, but it's of course, yeah, and it absolutely usually makes sense. Yeah, 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 yeah. Hmm? No, I don't know. Because that one Ewing patient, interestingly, had also not like high PD-1 expression and so on. And I think the issue is, the problem is it's really rare disease, and what we really need to do is to collect biomaterial, 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 biomaterial and get money, 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 money to learn why one patient is responding and the other not. And I think, like for example, lung cancer and breast cancer, the treatment, they now also became like rare diseases because they have so many subgroups and they had the chance to learn so much. But I'm afraid that also a 1 in a million Ewing sarcoma has also a lot of subgroups, and possibly that you will have to stratify and to treat with to yeah, at least for these high risk patients. Yeah. 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 Absolutely. Money for research.